continuing to look at anatomy with respect to motion as a central point of our network of meaning or our semantic network. We're looking at hip external rotation. So as is consistent, our objectives is to have a specific discussion of what hip external rotation is with respect to planes and axes, general discussion of muscles that generate this motion, as well as the neurovascular bundle associated therein, and areas to assess and treat should issues with hip external rotation be suspected by the practitioner or reported by the patient. Quick review of our planes. The sagittal plane is a 50% cut of the body left to right. Horizontal or transverse plane is a 50% cut of the body top to bottom. The frontal or coronal plane is a 50% cut of the body back to front. Your axes are perpendicular to the planes. The sagittal plane has a horizontal or transverse axis. The horizontal or transverse plane has a vertical axis, and the frontal or coronal plane has an anterior to posterior or posterior to anterior axis, depending on the terms you like. With respect to the anatomical position, so the legs more or less straight up and down underneath the torso or underneath the pelvis, external rotation is considered turning of the thigh away from the midline of the body, or the foot away, the toes will point away from the midline of the body in the totality of the movement. So it's movement away from the midline of the body in the horizontal or transverse plane about a hypothetical vertical axis. The hip being a ball and socket joint, it is multiplanar and multi-axial. Therefore, there is no actual axis of rotation. It is dependent on the muscles themselves, but your hypothetical axis would be a vertical axis in the horizontal or the transverse plane. So again, the toes would turn outward away from the torso, so they point out to the side. Now, with respect to the hip joint, something that should be noted is that a lot of the terms that we're going to use, flexion and extension, stay in the sagittal plane, whereas abduction and adduction, you can have horizontal abduction and horizontal adduction and horizontal abduction. The term is appropriate, but the plane in which it would occur would actually be the transverse plane in this case. So this is just a general discussion about the hip, not necessarily this specifically hip external rotation. So the leg could go straight forwards and come towards the midline. That would be adduction, adduction, but it can happen in the transverse plane, and hip abduction can happen in the transverse plane. Hip internal and external rotation can do the same thing. It can happen in the coronal plane if the leg is out to the side. So if the knee is pointing to the side of the body, internal rotation would be the toes or the foot moving towards the back of the body. External rotation would be the hip moving towards the front of the body, right? So this can get kind of weird because the hip is multi-axial, multiplanar. So internal and external rotation, or medial rotation, rotation towards the midline of the body, and lateral rotation, or rotation away from the midline of the body, can occur in multiple planes with respect to the hip because it's a ball and socket, because it's multiplanar and multi-axial. So it gets a little bit weird having those discussions. However, when you hear about hip external rotation, it is generally referring to movement in the horizontal or transverse plane and the toes, or the thigh, moving away from the midline. So the net result would be the toes would face away from the midline of the body or towards the side of the body. And that happens in about the vertical axis, or the hypothetical vertical axis. With respect to muscles, you're looking at a lot of muscles here. So muscles that are either considered part of the lateral rotator group or considered to aid in some degree with hip external rotation or hip lateral rotation. You're looking at the iliopsoas, the posterior fibers of the gluteus minimus and gluteus minimus, not the anterior fibers, because those are considered internal rotators, but the posterior fibers of gluteus minimus and gluteus medius are external rotators. Generally speaking, the gluteus maximus would be termed an external rotator. However, it seems to be more focused on the inferior fibers of the gluteus maximus, the sartorius, the quadratus femoris, both internal and external obturators, or obturator internus and obturator externus, depending on the terms that you like. The superior and inferior gemelli muscles, or the superior gemellus and inferior gemellus, depending on how you like to say it, and the piriformis muscle. So that's a lot of muscles that will generate lateral rotation or external rotation of the hip, which means that your neurovascular bundle, so on the muscles themselves rather, you've got to check the lumbar column for the psoas, to some degree anyways, it doesn't necessarily move the lumbar column aside from when the patient is in supine. The iliacus, so now you've got to consider somewhat anterior and medial portions of the thigh. the posterior gluteus medius and minimus, then you've got to be on the back side of the trochanter, the top of the trochanter, the top posterior portion. The inferior gluteus maximus, you've got to be running around the trochanter again, the posterior side. The sartorius, now you have to consider anterior fibers or the anterior thigh, the quadratus femoris, medial thigh, more or less the obturators. You're not really going to get to them particularly well, but the movement will indicate, or generally moving the thigh in relation, or the femur in relation to the pelvis. The piriformis and the gemelli muscles, you're considering the posterior aspect of the greater trochanter. So just on the muscles alone, you've got to run around the whole trochanter and consider to some degree the medial compartment of the thigh and the anterior compartment of the thigh. So this becomes a very large area with respect to identifying the muscles that are going to have problems if there's a problem with generating external rotation, or really more accurately, if external rotation is preferred. So if the leg likes to be externally rotated, then it's probably going to be at least to some degree the muscles that externally rotate this that are going to have high tone. They won't relax and allow for internal rotation or allow for a neutral position of the leg. Now, something to note, when you put a patient in supine, oftentimes you will see some people's feet stay straight up and down, some people's feet will fall to some degree away from straight up and down, and then some people's feet are almost splayed all the way out. Now, there is something to be considered with positioning a patient in supine and just the general curvature of a body. You want to make sure that you test the motion to determine whether or not the thigh or the leg, specifically the thigh or the hip, is externally rotated, on account of the fact that the position can make them look externally rotated when they will freely internally and externally rotate, or when the thigh and the hip will freely internally and externally rotate. So you have to test the motion. The reason I say this is because sometimes when somebody has a slightly larger gluteal region, and they end up in supine having a little bit more lumbar extension because either the muscle or the fat of the gluteal region projects a little bit farther back, what's going to generally happen, and this also happens to some degree with essentially a posterior leg or the region of the calves being more muscular or larger generally, you just put this point of meat around which the legs will fall outwards, right? So sometimes it's just because there's more mass posterior to the body with respect to the lumbar column, so there's more projection backwards in supine, and then the legs fall out or the feet fall out, but the hip moves freely internally and externally. So you have to test the motion, because the supine position can trick you visually, which is why you test the motion. With respect to the neurovascular bundle, you're looking around the whole thing here. You're looking at the lumbar column or lumbosacral plexus. You're going to have some degree of direct fibers from the lumbar region to the psoas. You're going to have the lumbar plexus involved, sartorius, right? You're going to have the obturator nerve for the external obturator, I believe. Then you're going to have direct fibers to the piriformis and the gemellis and what have you. So that's in the sacral region. So you've got to check the lumbar column. You've got to check the posterior aspect of the pelvis. You've got to check the inguinal region, the anterior soft tissues of the thigh, the medial soft tissues of the thigh on the neurological side, as well as on the vascular side. So the easiest way to say it is the neurovascular bundle means you got to go lumbar column, posterior aspect of the pelvis. Then you've got to go to the inguinal region, the anterior soft tissue of the thigh, and the medial soft tissue of the thigh. You've got to chase the whole thing if you're thinking about the neurovascular bundle, which is, again, what makes the case for paying attention to your assessment findings with respect to motion, which will allow you to behave best for what you find based on motion dysfunction, as opposed to chasing the neurovascular bundle just because you think it's a good idea. Base your treatment on your motion findings. It'll likely be somewhere in the regions we're discussing. However, if you're paying attention to the neurovascular bundle and not paying attention to the motion dysfunction, it's easy to miss what's right in front of you. So as we noted, as far as areas of consideration for assessment and treatment, the lumbar column, the inguinal region, the posterior soft tissue of the thigh, the posterior region of the greater trochanter. I would say you have to run the whole trochanter. Also look at the anterior soft tissue of the thigh and the medial soft tissue of the thigh. Anytime you're dealing with the lumbar region, rebound tenderness in the abdomen is an immediate red flag. It's a visceral pathology that you can't identify. You refer that out. A known fracture or a known tear is a red flag. You do not treat. You can treat the patient, but you don't treat where the fracture or the tear are. Suspected fracture or tear, you refer out. If there is no fracture or tear identified by another professional, then you can have some reason to believe you can treat the area. However, you're still very cautious. So those are your areas of consideration for assessment and treatment with respect to hip external rotation or hip lateral rotation, depending on the term you prefer.